We on? Good morning. Thank you everybody for joining us today here on our webinar with Australian Women's Health Alliance. And I'd like to thank all of our guests as well. Today, my name is Sandra Creamer and I'm on Yorta Yorta country down in Naarm. And I'd like to acknowledge all the traditional lands that you are all listening to us from. So thank you very much. And welcome to our first episode for 2026 in our collaboration with Women's Health and Wellbeing series called Healthy Women. I'm your co-host and I'm a Kalkadoon Waanyi person. I'm the lawyer and I'm also the CEO of the Australian Women's Health Alliance. I'm here today with you all co-hosting with Associate Professor Nina Lansbury, a non-Indigenous ally who we've worked very closely with in regarding health from the School of Public Health at the University of Queensland. And I'm also here with ladies from the Heart Foundation and also other women who are involved in the message of heart, which is we know is really important around this country at the moment, and especially for our women to hear the conversations that we're going to bring and the information that our guest panelists will bring to you today. So again, thank you all for logging in. I'd like to also pay respects to all my elders past and present. We've been delighted to see so many people registered today for our event, and our motivation for this series is to bring you the human face, as we always do in our series. The story is about our health, and we hope to translate key research messages and put the power of decision making into the hands of you as women who are online or into women as carers. We will do this in a yarning style conversation so that each webinar episode has a relaxed and inclusive approach. Each episode will reach out through our network to bring you high quality health researchers, and this is tailored for listeners. And what we're trying to do is reach to women sitting at home or to workers, to anybody, to all people who have an interest in health, and again, to bring that human face to the story. And what we're doing is to give you a clear understanding of options that you have and to make informed decisions about your health and the people that you may care for. We particularly want to communicate to women from priority groups, from migrant backgrounds, from Aboriginal and Torres Strait Islander backgrounds, from different levels of education and from different paid and unpaid roles in our society. In doing so, we hope to bring the invisible women to the centre of our accessible conversation. So that brings us today to focus and the excellent guests that we have in women's heart health. Next week, as we all know around Australia, is Heart Week. And we want to discuss the range of challenges that women face with their heart health, which can be different from men's heart health. You will learn today, what you should learn today will empower you with the latest information, symptoms that you need to be aware of, and what you can ask of your health care providers and services to achieving and maintaining the best heart health. Today's webinar will explore a range of heart health issues from the causes and solutions to rheumatic heart disease, especially in remote and Indigenous communities. The reasons why the healthcare system and professionals might not deter heart problems in women is that the lessons learned from a lived experience and heart health advocate and many useful references. So this is what our guest panelists will give you today on how to recognise those women, detect heart problems. Our speakers include rural health development specialist, nurse and Noongar woman, Aunty Vicki Wade. Thank you for coming on today. Heart Foundation manager, Lee Smith, who is also a board director for Australian Women's Health, and with Lee, we also have heart disease lived experience representative and heart advocate, Christine Tawtel. Thank you all for coming here today, and I know that you'll be very informative and give great messages to our audience. And after we've heard from each of our speakers, we will answer the questions that you can post in our Q&A on our screen. Nina Lansbury, who is here with us, will manage the section and then provide a closing summary of what we've heard. So, Aunty Vicki, I'll go over to you today, who will be our first speaker. You're a specialist nurse in the rheumatic heart disease and you're a Noongar woman with over 40 years of experience in heart at state and national level. We know that you're a recipient of multiple national awards and you do have contributed to the Australian Health Service policies, delivery and research, particularly in relation to Indigenous heart. We know that you're a well-known Indigenous health equity and you sit on the National Close the Gap Steering Committee and you're a previous board member to the Congress of Aboriginal Nurses and Midwives. So today what you will do is we'll have a discussion where you can discuss in your role in Aboriginal communities and losing young women early, and also in that coroner's inquest that we know that you've been involved with. And you'll share some stories of rheumatic heart disease where you will speak beyond statistics and you will speak from the heart, from your heart. So thank you very much, Aunty Vicki, if you'd like to go ahead.
Yeah, thanks, Sandra. And it's a pleasure to be talking to everyone today. Acknowledge that I'm on Waanyi land. As a Noongar woman, pay respect to all elders here too. Aboriginal women's heart health, it's always been very important to me. I've lost so many family members from heart disease, including rheumatic heart disease. And these have been strong Noongar women whose lives have been cut short by heart disease and rheumatic heart disease. These have been my nieces, my aunties, and my cousins. When I lose, these strong women in the community that are looking after our young Gulangars, our young children, and also I see it as it's almost like a library where you have a book and you can pull that book out. It's like an encyclopedia of knowledge. So when we're losing our young women, we're losing some knowledge, some Aboriginal knowledge. And it's often hard to get this back because although, we're great storytellers, that sometimes these Aboriginal women have gone through a lot of trauma, particularly in my family. So there are stories that are lost. So it's very, very dear to me, heart health. I just want to, and I know that, we have heart health, we have bad hearts. I call it the Hayward heart. I have the Hayward heart. And we die younger. We have our diseases much earlier. And we know this because we're continually going to funerals of our young women who have died from heart disease. So beyond the statistics is that's the reality. That's my lived reality and my lived experience. I do now, Sandra, want to turn to rheumatic heart disease. I've been working in that space for a number of years now. There's about 12,000, close to 12,000 people in Australia now living with acute rheumatic fever and rheumatic heart disease. Over 80% of these are First Nations, so Aboriginal and Torres Strait Islander. And most of these are women. So there's 28% of these people are under the age of 25 and 66% are female. So we're losing these young women. Every week in Australia, 2 First Nations people die from rheumatic heart disease. Some people don't even know what rheumatic heart disease is in Australia. So, what's wrong with this? What's wrong with two people dying, 2 First Nations people dying a week? Firstly, it's 100% preventable. It was in Australia in mainstream around the 50s and 60s. We saw a lot of non-Aboriginal people with it, but it has been eliminated in mainstream Australia, except our Aboriginal women have got the brunt of this disease and are dying prematurely. It's been eliminated in every other developed country. And when you look at that statistic of two people a week dying, it's not 70-year-olds, it's not 60-year-olds, 50-year-olds. These are our 30-year-olds and our 40-year-olds. These are our women who are caring and nurturing through our cultural obligations, our young ones. And as I said, losing our cultural knowledge. I was going to say I had the privilege or the pleasure of being invited to the coronial inquest. 3 young women died in Dormagee within an 18-month period. And these women, 3 of them were under the age of 30, 33. One of them had 2 children. So the deaths triggered off a coronial inquest. And it wasn't pleasant at all, because I read over 6,000 medical records, autopsies of the 3 women. I read all the affidavits of the community, all the doctors' reports, and I cried, I went away, I came back, I read more, I cried. It was heartbreaking for me as an Aboriginal woman to see that these 3 young women had preventable conditions. They didn't need to die. They were coming into hospital. Me being a cardiac nurse, so I've had many years of experience of being a clinical nurse consultant in cardiology. And I said, oh my goodness, this young woman is coming in with heart failure. She's known to have rheumatic heart disease. Her valves aren't working. She's in heart failure, yet she was given a Panadol to go home. And that was heartbreaking to me, being an Aboriginal woman plus being a nurse. Within the notes I read, it's very, very important that we get the medical records right. A doctor wrote that this person is non-compliant. So in fact, every other doctor, nurse, person who was writing in the clinical notes, it almost gave them permission to say they're non-compliant. One of the Aboriginal doctors that I've known for a long time, his report said, in fact, this young woman was over-compliant. She was taking her medications on time. The other sad thing within this report was that there is still ongoing racism, ongoing discrimination, and unconscious bias. And the report ended really with, the health system has failed these women. They have failed these young Aboriginal women with rheumatic heart disease. I came up with a model around how can you improve the communication and the relationships between the community and the health services. And it was really hard because the community didn't trust the health services, and the health services didn't really understand the Aboriginal community, didn't understand what the cultural obligations of these people were. So there was a real distance between, it was very didactic. They didn't understand. They were scared to go into hospital. They were saying they're not coming into hospital, they're not looking after themselves. So I came up with this model, and in the middle of it, it's called an ethical space where we have to work. So I think a lot of our Aboriginal women coming into hospital are still frightened to come into hospital. And to me, this is an ongoing legacy of colonisation. And within heart disease and within rheumatic heart disease, we know that, people who experience discrimination are more likely to have heart disease. I think it was about 70% of our people experienced significant stress in the latest report for, self-reporting of our own health. So these ongoing legacy of colonisation, to me, it's almost like the pointy end of colonisation, these chronic diseases we're seeing today, and we're seeing them more in our young women and children too. So the majority of people who are getting acute rheumatic fever, which leads into rheumatic heart disease, are young kids from the age of 5. We have diagnosed young kids at the age of 3 up with rheumatic heart disease. And I think that's really important to me, because prevention is important to get the word out to our communities. So when I go out to communities, I always try and talk to the women who are looking after the young children, go into the schools, going into the preschools, the women's shelters, always aiming a lot of my raising awareness and education with the women, because I know that the women are the nurturers. Every remote community I go into are matriarchal societies. They have, and we have certain obligations, cultural obligations, where we have to care and nurture for our children and raise our children. If we don't look after our Aboriginal women's hearts, who's going to be there to look after our children? So if we strengthen Aboriginal people's knowledge, women's knowledge around heart health, and we prevent acute rheumatic fever, prevent heart disease, we are going to benefit everyone, family, young children, and community. I think that's really, really important.
Sorry, Sandra, do you want to just unmute?
Yeah, thank you very much, Aunty Vicki. And I think what you said is really important. I think that people really have to be aware, and I think people don't understand the high rate of rheumatic heart diseases that are out in remote communities. So, to bring that story to the voice to everyone listening here is really important, because we know that it's very serious, and I'm quite aware of the Doomadgee matter as well, which was very sad. I mean, we have young girls who with misdiagnosis of any sort of heart disease. But I'll go on to our next guest, and again, thank you very much. So we'll now turn to the Heart Foundation, which provides guidance on supporting heart wellbeing, including calling for a focus on women. Lee Smith is the National Manager of Population Health and Wellbeing at the Heart Foundation. Lee has over 20 years of experience in health, including a range of senior executive and leadership positions within the non-profit and for-purpose sectors. She brings a wealth of expertise in primary health care, health equity, program delivery, commissioning, and governance that enhances health outcomes. Additionally, Lee and Aunty Vicki have been active in Canberra, engaging with the Australian government on a newly established ministerial expert panel on women's health, focusing on women's cardiac health. And I just want to congratulate you both for that, because I did see the media release about that. So, it's a great honour, I guess, for both of you to be on that. But Lee, I'll hand it over to you now, and it'll be great to listen to what you have to say. So Lee will focus on women's health and on why women's cardiac health is a priority. So thank you very much, Lee.
Thank you, Sandra and Nina and the Australian Women's Health Alliance for inviting me to be part of the webinar today. And thank you to, yes, my dear friend and colleague, Aunty Vicki, who also always shares such incredibly powerful and moving stories, and we always learn so much from her. I'm joining you today from Larrakia country in Darwin, and would like to pay my respects to the elders past and present, and recognise the enduring connection and care of country and culture. So let me start with that simple question of why is women's heart health a priority? And the answer is because it has such a profound impact in our lives and that of our families and communities, and outcomes for women are not equal to that of men. Every day, 18 women die of heart disease in Australia, and Australian women are more than twice as likely to die after a heart attack than men are. There's more than 500,000 women are living with heart, stroke, and vascular conditions. And behind all of those numbers, there's real women lives and impacts. I do just want to note that in this discussion today, I'm not a clinician, so this is general information, and there will be a key message that if you have any concerns at all, go and speak with your GP and have a discussion about that. What we know is that women's heart disease has been under-recognised, underdiagnosed, and under-researched for a really long time. And for many women, the risk is underestimated. The symptoms can be missed or easily explained away, and getting the right tests and treatment can take longer than it should. Heart disease in women doesn't always match that traditional stereotype that we often see, that familiar kind of version of a man clutching his chest with sudden crushing chest pain and pain in the arm and not much else being talked about. Chest pain can happen in women too, but it might feel different to that. And women often describe that pain as pressure or tightness or squeezing rather than a big crushing pain. But women may also have symptoms like pain or discomfort in the arms or shoulder, the back, neck or jaw. There might be shortness of breath, sweatiness or feeling dizzy or lightheaded, unusual fatigue, heart palpitations or nausea, or sometimes no pain at all. And the symptoms can occur while resting or even asleep, and not just during physical exertion. And the pain can sometimes be subtle or less intense. It can come and go. And the reason why that matters is those symptoms can feel really everyday or easy to explain away. You might be rushing between work and notice you're suddenly feeling breathless in walking to the car, or you might rationalize that I'm just unfit or I'm overtired. You might put nausea or tiredness down to stress or a virus, or you haven't been sleeping well. And you might hear that list and go, I actually feel some of those things on most days. And that's what makes it really hard, especially when you have family or caring responsibilities alongside your work and personal life. And I think a lot of women put off getting checked, or tell themselves, rationalize it away, or tell themselves that they'll deal with it later. So there's a really key message that if something is new, if it's worsening or unusual, or it just doesn't feel right, it's really worth acting on. Trust your instincts and don't talk yourself out of it, and go and see a healthcare provider and get a heart health check. Women can do a lot to support their own heart health, and I'll talk about that a little bit later, but I think it's also important to name that there's system issues behind many of the experiences, and the disparities that exist in cardiovascular prevention, treatment, and management between men and women. For decades, the research and therefore the clinical practice out of that was built around men, sometimes even using only male animals or male mice in the lab studies. And that has shaped prevention, treatment, and management, and also what gets taught as typical. And that can contribute to that under recognition, under diagnosis, because anything that doesn't match that male default may be treated as less specific or less urgent. And I think there's a key need to shift the language. Women's symptoms are often different. They're not atypical, and they often get called atypical. Women can also get let down by how care is organised. There's short appointments and there's often time pressures, so it can mean that symptoms aren't explored in more detail. And we know there's often structural barriers around costs and transport and waiting lists that can delay care, and fragmented services that leave people with no clear follow-up. And then you add communication barriers, language and health literacy, that lack of culturally safe and trauma-informed practice and caring responsibilities. You can see how easy it is for women to fall through the cracks. So when we're closing this gap or addressing the disparities, it's not only about telling women to be more aware or do more or recognise the symptoms. It also requires the system to respond. It requires better knowledge and practice, guidelines and education that recognise the sex and gender differences, and measuring what happens, having sex disaggregated data so we can find and fix that variation that really shouldn't be there. Another thing to keep in mind is that heart health matters at every age. Often it's seen as something only later in life, but a woman's risk changes over time, and it can build quietly in the background as well. So prevention and early action across the whole life course really matters. And there's some life stages that are especially important. So in adolescence, there's certain factors that might increase your long-term risk of developing cardiovascular disease. Things like early age or late age for your first period, and polycystic ovarian syndrome. During pregnancy, complications like preeclampsia and gestational diabetes can be a flag for higher risk later in life. So they really deserve a clear follow-up and plan with the GP after birth. Or having a low birth weight baby or a baby born prematurely can also increase a woman's risk of developing cardiovascular disease as well. And menopause is another really key time. As our hormones change, blood pressure and cholesterol can shift, and it's a really good time to check in on heart health. During menopause, women are at a greater risk of developing abnormal cholesterol levels, high blood pressure and sugar levels, and excess body fat around the waist. And we know that women who experience early onset menopause, so 45 years or younger, may also have a greater risk of developing cardiovascular disease. So we really see that heart health should be part of routine care at all different points in life, in school, in GP visits, in pregnancy or menopause visits. Are really good check-in moments to talk about risk or follow up or get a plan in place. And we've heard from Vicki around the experiences for many First Nations women, and I don't think we can talk about heart health without acknowledging equity and that not all women face the same risks. The impacts of heart disease can be shaped by where you live, your culture, language, disability, trauma, and the caring roles that we often hold. So equity, intersectionality, and cultural safety, they can't be add-ons. They need to underpin everything that we do. And that really means designing information and services so they work for different women and communities, including having English language and culturally appropriate supports where needed, and also ensuring that there's care navigation or continuity so women don't fall through the cracks at the key transition points. Sandra mentioned the Australian government's ministerial expert panel on women's health. So the good news is that there's already strong work underway. Vicki and I have been lucky to sit on that panel. It brings together government, clinicians, researchers, peak bodies, advocates, and really importantly, women with lived experience to look at practical changes that can improve outcomes or close those disparities and strengthen accountability. So the panel's job is to look at what's not working, recommend what needs to change across prevention, diagnosis, treatment and follow-up and across the life course. And the panel will be meeting regularly throughout the course of this year. There'll be 2 key consultations, one with women who have lived experience and one with health professionals and clinicians, to help identify and inform where the biggest gaps are, what supports are missing, and where future investment would make the most difference. There's already some really clear priorities and actions that have come out of that we've heard in that panel, that we've heard through the Heart Foundation and other women's health organisations and globally as well. So the key things are recognising women's symptoms earlier, and that is for both the public and for health professionals as well. We need to really strengthen prevention and follow-up, make sure it's easier to understand risk and get the right care at the right point. We've recognised that we need to improve CPR and AED for women, including women-specific examples and training so people can act more quickly. This is a real disparity area, and women studies show that women who collapse in public are 14% less likely than men to receive bystander CPR or AED. There's hesitation, there's concerns, and there's misrecognition, which is part of that problem, which is why we really need to ensure that CPR and AED training includes women-specific scenarios and mannequins. Most mannequins are men and not women. So that's practical things to progress. We need to grow a workforce that women can and want to access. We know only 4% of cardiologists are women, and women often would prefer to see a woman cardiologist. Our partner organisation, Her Heart, has a find a female cardiologist on their website. If you go in there, you can look at where you could find a female cardiologist in your area, and also a really helpful card that you can take to your GP to support and guide you with the right questions to ask. We need to put equity and women's voices, lived experience at the centre of what we do, and we really do need better data and evidence so that our guidelines and our training and services can reflect the needs of women, and we can track if things are improving. There's a lot of great heart health information that already exists. It doesn't always reach the women who need it when they need it. So it's not just about awareness, but it's making sure that the information is shared clearly, it's at the right time and in the right way. Before I wrap up, I just want to acknowledge there's a lot that we need to do to fix the system, but there's also actions that we can take personally. And there's a few basics that genuinely make a difference to protect your heart. Understanding your risk factors and the role that they play in the onset of heart disease, high cholesterol, blood pressure, obesity, diabetes, stress and emotional stress, and smoking and inactivity. So understanding the risk, knowing your numbers, and getting a heart health check are all really helpful. Eating well, moving more, maintaining a healthy weight, avoiding tobacco and limiting alcohol, there's supports available, and prioritising sleep and mental well-being where you can. If you're looking for any information or resources, the Heart Foundation website is a wealth of information. We run awareness campaigns. As Sandra said, it's Heart Week next week. And there's also a suite of practical information, tools, programs, resources. There's walking groups that you can look for in your areas, and a lot of great advice and recipes as well. Thanks, Sandra. I'll leave it there. Oh, you're on mute again.
Yeah, thank you very much, Lee. That was really great information. And you know, I'm surprised, but I'm not surprised about how they've just tested mice and male mice rather than female mice. People don't really realise, I think, that, you know, we all have a different DNA and different things that need to be just done for women. So that was very informative. We'll move on now to our next speaker, our final speaker, Christine. I welcome you. And Christine is the co-founder and deputy chair of Familiar Hypocholesterolemia. I'll let you actually explain where you're from, Christine. And, you know, it's great to see that you're a co-founder in this doing what you're doing. And it's great to see women like yourself form something that you need to think that is informative for other people, and what you've established to advance health by improving Australia-wide awareness, understanding and access to diagnosis and treatment of individuals and families living with generic high cholesterol, including FH, which you've founded, and you will explain that, and also your extended families where you're aware of the inherent and high cholesterol, but through a lack of information, which was never properly managed. And, you know, I just want to say myself personally, I think that this is, I know I went to the doctors myself and they said, oh, you know, you've got a high cholesterol, and I've never heard of anything like that before. I'm now understanding, get a deep understanding of why and what I've got to do to be able to bring that down. So I really look forward to what you've got to say, Christine. I know that you're very passionate, and it'll be great for you to help identify in the communities and supporting individuals through this conversation that you're going to have with us. So if you can share your lived experience with us through this. Thank you, Christine.
Thank you, Sandra. And thank you, Lee and Aunty Vicki, for your wealth of stories and knowledge. I'd like firstly to acknowledge that I'm speaking today from Noongar country in Western Australia, and I would also like to pay my respects to elders, past, present, and emerging. So you heard Lee say a few minutes ago that cardiovascular disease is a leading cause of death, which it is. Approximately 1 woman every hour in Australia dies from cardiovascular disease, which is twice the rate of breast cancer. So I am the co-founder and deputy chair of an organization called FH Australia, and I have a lived experience of heart disease. Lee also mentioned that cardiovascular risk changes across the life course, and that is an important part of what I'm going to be speaking about today. She also mentioned that classic risk factors include things like high blood pressure, obesity, diabetes, and high cholesterol. And that high cholesterol point is where I come into the picture, but specifically, I want to speak to you about inherited or genetic high cholesterol, which very few people know is a thing. So FH stands for familial hypercholesterolemia. It's a really big word, so we typically shorten it just to FH. Familial means genetic or inherited. Hypercholesterolemia means high cholesterol. It's a genetic disorder which leads to LDL, or the bad cholesterol, which you've probably heard bandied about in public discourse. It leads to high levels of LDL circulating in the bloodstream from birth, owing to a genetic variant, which prevents sufficient clearage of cholesterol from our bodies. And undetected and untreated, LDL circulates at these high levels for years and settles prematurely in the coronary arteries. That is a process known as atherosclerosis, decades ahead of the average person. So the stakes, or the problem with this, is that the prevalence or common rate of FH in the community is 1 in 250 people. That is one of the most common genetic conditions that there are. That equates to about 100,000 Australians, 20,000 of whom are children, and only about 10% are aware of it. So roughly 90,000 Australians are walking around building up atherosclerosis in their coronary arteries and are unaware. The stakes are that life expectancy is shortened by 20 to 30 years if it's undetected and untreated. That is significant. So undetected and untreated, 30% of women will experience a coronary event by the time they're 60, 50% of men by the time they're 50. It is 100% preventable, 100% preventable. Now, unfortunately, FH has a 50% inheritance pattern. So because it's genetic, you cannot diet or exercise your way out of it. So every child that an FH positive person has a 50% chance of inheriting it. 1 in 5 heart attacks under the age of 45 is attributed to FH. So inherited genetic high cholesterol, 1 in 5. So there's a great deal of importance that we place on what we call cascade testing, which is the testing of families. So if you know that high cholesterol runs in your family and you get tested for FH and it's positive, it is imperative that we cascade test through the family branches. But I'll tell you a little bit about my story. So I knew that high cholesterol ran in my family. That's typically an expression that we hear. Oh yes, high cholesterol runs in my family. My mom had it, my auntie had it. But I had been pretty diligent, and I had started on statins in my 20s when they first came on the market in Canada. I'm Canadian by birth. So in the 1990s, statins came to market, and I was on them for the next 30 plus years. Through a number of moves and relocations and changes in my, my life journey, I was managed by a series of GPs, all of whom I had to share my story with, that I had high cholesterol, it ran in my family, and I've been on a statin for a number of years. They would all continue. They would test me. They would look at my lipid panel, my numbers, and they'd say, yes, you're fine, and keep me on the same statin dose I had been on for years. But I was always managed as if I had lifestyle caused high cholesterol, meaning I had a bad diet or didn't exercise sufficiently. Nobody ever said the words familial hypercholesterolemia, genetic, FH. Those words were never uttered, despite my reiteration multiple times that it ran in my family. So consequently, my LDL, that bad cholesterol, was never driven low to the point that it needed to be, that I would stop the risk of building atherosclerosis. And because I was exposed to that elevated LDL from birth, that lifetime of exposure, including taking what we call statin holidays when I was trying to get pregnant, when I was pregnant, when I was breastfeeding, and this is specifically a women's issue. From the time that women begin to consider conception through pregnancy, through birth, and through breastfeeding, and through multiple children, women can be potentially off of lipid-lowering therapies for up to a decade. That is a serious risk. So because of some of those statin holidays, and then in addition, I entered menopause relatively early, in my early 50s. I went to see a cardiologist at that time, owing to an unrelated but menopause-related issue. She decided to do a CT angiogram just to rule out cardiovascular disease, but she said, "You'll be fine. You've been on statins for 30 years. I wasn't fine. I learned that I actually have significant coronary artery disease, putting me in the 99th percentile for my age. So why was that? Again, because I was treated as if I had a bad diet. I wasn't treated as if I had genetic high cholesterol, and the risk was never recognized and was never factored into my care. So that was a shock. And that's when I really began my patient advocacy journey. So I was referred to a lipidologist, that's a specialist who works in the cardiometabolic space at Royal Perth Hospital. Now, we are extremely fortunate here in Australia that we are surrounded by some of the FH global clinical research and thought leaders. We are incredibly fortunate. We are world leaders in this space. And Gerald Watts, who was my case manager at Royal Perth Hospital, is one of the original global leaders. So he put me on a new protocol that hopefully will stabilize my coronary heart disease and stop it from advancing. And he recognized my urgency in wanting to make changes around public awareness for FH for people like me, so that other families didn't have to share my experience. And he put three of us together, three women who came from three different professional backgrounds, three different health experiences, and together the three of us founded FH Australia in 2023. So FH Australia is the patient voice. So we are patient-founded, patient-led, patient-focused, with representing individuals and families living with inherited high cholesterol, both FH and another type of inherited high cholesterol that is getting increasing scrutiny over its role in heart disease acceleration, and that's something called elevated lipoprotein A. So we operate on the principle of patient advocacy, which is essential in improving healthcare navigation, patient-clinician dialogue, and the broader patient experience. We influence health policy and service delivery always through that lens of lived experience. We provide a platform for patients to share their experiences, their needs, and their concerns, humanizing the realities of genetic high cholesterol and transforming those experiences into opportunities for patients to build their health literacy and skills to better advocate for themselves and their families and to live well with these lifelong conditions. Our three key pillars at FH Australia are to support, to educate, and to advocate. Something that both I think Lee and Aunty Vicki referenced was that the health system to some degree is broken, and that is also true for FH. There is a serious disconnect in knowledge between healthcare and the prevalence of FH. So the average GP, if you rock up at a GP and have a lipid panel done, will not think about FH unless you bring it to their attention, unless you advocate for it, unless you know that you've got heart disease in your family or that you've had high cholesterol and it's run in your family for years. This is equally true with lipoprotein A, which is that second form of genetic high cholesterol, which can accelerate atherosclerosis. So it's a real double whammy for people if they have FH as well as elevated Lp(a). It's even more common. Up to 1 in 5 Australians have elevated Lp(a). Testing is not currently covered under the PBS. and can cost between $40 and $80 at your local pathologist. But a test is only needed once in a lifetime. So unlike cholesterol, which can rise or fall depending on lipid-lowering therapies, your Lp(a) is your Lp(a) score for the most part from birth. But again, testing is rarely offered. So even though, and this is a position of FH Australia, is that many clinicians don't want to offer Lp(a) testing, or Lp(a) is what we call instead of lipoprotein A. They don't offer Lp(a) testing because they're concerned about being alarmist and causing alarm in their patients when there's no treatment currently available for Lp(a), which is true. There is no current treatment available for Lp(a), but it is on the horizon, and we expect within the next year that treatment will be available. However, as a patient-focused organization, we strongly disagree with that perspective. We believe that patients have the right to understand their clinical risks and to respond accordingly. So even things like improving your lifestyle and your diet and reducing other cardio risk factors, such as your glucose or your blood pressure, can have significant impact on lowering that risk. So what is the solution for us? So the solution is improved national awareness. Again, there is just too little awareness about the prevalence of genetic high cholesterol. Early treatment, and this is the key, early treatment of FH, if it's detected, eliminates the risk of cardiovascular disease. It is entirely preventable, and we need to prevent the preventable. So we need universal screening. This is something that we're advocating for at both state and Commonwealth levels. Ideally, you should be screened in childhood to understand if you do have FH. We do consider FH to be a pediatric condition, not a cardiovascular condition that is discovered in your 50s or 60s. That is a byproduct or an end result of undetected FH. If it's detected in childhood, you completely return life expectancy to normal. Starting treatment in childhood also means that you can remain on a low-dose lipid-lowering therapy probably for the rest of your life, never having to escalate like I did to a high-dose statin, where you also then have to bear the potential side effects of those high-dose statins. And there are several different types of lipid-lowering therapies on the market. So if one doesn't agree with somebody else, with a person, there are many others that they can try. And there are many new therapeutics coming to market, including things like DNA silencing and DNA editing, which may eliminate the disease for a person in a next generation. So I guess the big takeaway message for me is know your numbers. Knowledge is power. As early as you can, make sure you have a lipid panel done. Insist on having an Lp(a) test done. It's once in a lifetime. And think of your family heart health history. All of those things combined can make a difference in your cardiovascular well-being. If you have the opportunity, follow FH Australia on our socials. We do a lot of campaigning around women's heart health. Next week is Heart Week. We've got a Heart Week event, a campaign happening. And if you look back at our January socials, we had a women's heart health campaign as well. And a lot of that is just short, digestible bursts of information that can help build your health literacy and potentially improve your cardiovascular outcome. So I guess that's it for me. Thank you very much.
Thank you very much. That was great information, Christine. I can't thank you enough, because I think, some of these things that it's a hidden conversation and people need to be aware, and especially as what you said, knowledge is power, and it was very, very great. I'll hand it over to Nina now, who will do a close summary of it, and to see if we do have any questions. Thank you, Nina.
Yeah, thanks to all our speakers. You've been amazing. It's been an information-rich webinar. We do have one main question in the panel, which is thinking about resources. Like, where are the resources that we need, and how do we find them, and what are they for? So I might just go in order. Aunty Vicki, if you want to talk about resources, then Lee, and then Christine. And I'll be taking notes, because we'll share around the recording and a summary, as well as links to these resources afterwards.
A lot of the rheumatic heart disease resources are on the Champions for Change program, where people with the lived experience with rheumatic heart disease are on the Heart Foundation website, Menzies School of Health Research website, and also NACHO, so our National Aboriginal Community Controlled Health Organisation, has some good resources. There's lots of resources too being held in communities themselves. So I see more and more resources when I go out to community that these communities have developed, especially the communities that are been given money under NACHO, so they're called the Rheumatic Fever Strategy. So the communities, there's at least 28 of those communities. But can I just say one thing to Nina, that William Shakespeare said, "One beautiful heart is better than 1,000 beautiful flowers." And I would like to say that one beautiful, strong, healthy heart is better than 1,000 flowers on your coffin. Thank you.
Thanks. I think the comment there around a lot of women don't know how to find the resources is true, and it's not only where to find them, but making sure that they're delivered in a way that women can read, understand, in consideration of, language, health literacy, culture, etc. And I think it's finding ways, as we are at the Heart Foundation, to increase that understanding and delivering more and more resources in language and in ways that women can access, that we're very keen to build on that, as well as that primary care and system challenge, so that the right information can also be given. I note Professor Linda Worrell-Carter, who's the CEO of Her Heart, and I mentioned some of the resources that you can find on Her Heart website as well, with the Find a Female Cardiologist and a great array of women's specific heart health information and tools and resources, and on the Heart Foundation website as well. Thanks, Nina.
Christine.
Yeah, and so specifically for any resources on FH or LP-A, we've got several on the FH Australia website under the resources tab. Also under the resources tab is a Find a Clinician, which lists all of the national FH friendly clinicians, because there are so many that don't acknowledge or consider FH. So I think the important thing here is just to understand, again, the difference between lifestyle high cholesterol and the genetic type of high cholesterol, which you have limited control over managing. So I think educating yourself on, if you have high cholesterol and you have a family history of heart disease, educate yourself on what the difference is. And you can do that on our website.
Fantastic. And those of you who are clicking through will also see that Women's Health Victoria's Cindy Tran has put some really useful links in the answers there, as well as Professor Linda Worrell-Carter. So that'll all be included in the follow-up email that you get. So just to summarize, and then I'll hand it back to Sandra and the speakers to give us their final takeaway message. We've just had a beautiful journey through women's heart health, well, heart health more broadly, but the specifics of what it means to women. So thank you to Aunty Vicki for talking us through what shouldn't be even a conversation we should be having in 2026 anywhere in the world, but especially not in this wealthy country with amazing a public health system, and yet people are dying, as you said, Aunty Vicki, in their 30s, especially women who are carers, and that's from rheumatic heart disease. And Aunty Vicki and I've got to know each other through a large research project looking at what are those foundations in terms of environmental health factors or housing aspects when people are living in unintended crowded situations in public housing that isn't well maintained by the owners, usually government agencies. That sets up conditions for strep A, skin infections, and throat infections. That recurrent infections lead to the conditions of rheumatic heart disease. So it's such a preventable story. And hopefully we won't be telling this story anymore because we've got these resources and understanding, and ideally we're all supporting improved conditions for living. And then Lee, you extended on actually the theme today really is all about prevention and knowing what symptoms to look for, and also this power, having the feeling of power that you can actually ask questions about your symptoms to your trusted healthcare provider. And that's probably another theme is, do you trust, are you wanting to go and seek health, and how do those health providers actually receive you, especially if you're coming from a different cultural or language background. But the Heart Foundation has so many resources and initiatives such as Health Week next week. And then Christine, the power of the advocate, whether you're walking beside someone who needs advocacy or you're even the patient who's then extending to advocate for the condition you have and then educating others. I think that's just so powerful. Again, it's not a situation that should exist, that early diagnosis and then that incredible prevention that can happen, especially for FH and similar genetic conditions. Yet into that space you've stepped, and for example, being here today, being able to share that story, I think will resonate with a lot of people. So I'll hand back to Sandra just for our final wrap up.
Yeah, thank you very much. That was great conversation, and I'd like to really thank all of you. I just want to make a quick note that there were some other questions, and what we'll do is trying to liaise with Lee and the other panelists to try and answer those questions. We will actually put those on our social media, some of the questions that you've asked, and to give you that information. It's really important that we try and do and deliver it. But I do hope that everybody enjoyed the conversation today, and what a great information sharing. This is what it is. It's about sharing. It's about bringing to the human face to the story. And I'd like to actually ask my three panelists just quickly, one key message that you'd like to take to the audience. Lee?
For me, I think is if there's anything that you're worried about, anything that's niggling, anything that you want to find out a bit more about, go and get a heart health check and see a health professional and have the conversation. We recognise there's system barriers, and it's really, really important that we've got a system that responds to women's needs, and the way that we access health services and information. But there's also important to understand the risk and feel empowered to take action.
Yeah, thank you. And I'll go to you, Christine, just one key message. Thank you.
Think of your family heart health history. Know your numbers. Get a cholesterol test. Get an Lp(a) test.
Yeah, thank you. Very powerful. And Aunty Vicki, one key message from you. Thank you.
Yeah, I think that, RHD is often described as a disease of poverty and disadvantaged. I think we need to see it as an issue, and more broadly to women's heart health. It's a basic human rights, and it's a social justice issue. Thank you.
Yeah, thank you to all of you again. And we hope that all of our audience take care of yourself and your loved ones during Heart Week next week, from May the 4th to the 10th this year, and every other day. What we'll do is we'll share the resources that we do have on to you in the email when you receive the recording, but we'll also share information from the Australian Women's Health Alliance next week during our Heart Week. So a healthy heart, everybody take care of yourself. And again, thank you to our audience for joining, and thank you to our great guest speakers, just so informative, and really appreciate those who have joined us today, or those who haven't joined us but will receive the recording. Again, thank you all very much. Thank you.